So our topic now becomes one of the largest on your exam, because if you think about what comes through a hospital laboratory day in and day out, 95% of the isolates are going to be bacterial, and out of those, generally they're going to be the gram-positive cocci. So this is a large chapter. I would suggest that you take it in chunks and not try to gut the whole way through it in one setting. But starting with chapter 3 here, we're going to talk about the medically important bacteria. And we're first of all going to talk about the minor issues of how we tell them apart as far as their anatomy, their physiology, and so forth. So our first few introductory pages here, we'll be talking about the classical microbiology that we still use today. So realize for many, many decades, we've known that bacteria stain differently with the gram stain, although it's really only been relatively recently that we figured out exactly why that was. But the gram stain historically differentiated two very major groups of organisms. And as you see here, when you put them side by side, they have things in common, but the things that they have separate from one another is, number one, a very different size of the cell wall. Notice very thick and heavily cross-linked in the gram-positive, very thin and not heavily cross-linked in the gram-negative. That is the major thing, and that is the attribute that gives them the characteristic of how they respond to the stain. Now, if you notice, both of these guys are shown having a capsule. Some organisms don't have one, but we'll talk about the function of that in a moment. You probably already remember that capsules make organisms slippery and therefore more difficult to phagocytize. Notice that my surface molecules on the gram-positive are teichoic acids, which function in adherence, or lipoteichoic acids. In the case of the gram-negative, it is the endotoxin molecule in the outer membrane that is terribly important clinically for causing endotoxin shock, as we spoke about in our first chapter discussion of infectious disease. So notice that in addition to the difference in the thickness of the cell wall, which is made of the same material, it's a polymer of N-acetylglucosamine and N-acetylmuramic acid, but much thicker in the gram-positive. The other major thing that is important about the difference is that only gram-negatives have an outer membrane. Notice both of the organisms have an inner membrane, and that inner membrane is responsible for active transport into and out of the cell. But the outer membrane is the site of residence of endotoxin, which is a hugely important molecule to the pathogenesis of the gram-negative. Now, because of the fact that the gram-negative has two membranes, there is a space created between them that we refer to as the periplasmic space. And that simply, as the name implies, is a space through which things will diffuse, either when they're coming into the cell, as might be a drug that we're using for therapy, or when they're diffusing out of the cell. And so if I have a gram-negative who is making an inactivating enzyme against a drug, like a beta-lactamase, remember that the holding of that enzyme in that space very close to the peptidoglycan cell wall could cause that drug inactivating enzyme to have a longer period of efficacy in delaying the advent of the activity of the drug. That's not to say that gram-negatives make more of these enzymes or less. It's simply to say that if one is made, then it is held near the anatomy of the bug longer and therefore can have a greater effect. Now, other than that, notice the porins, which are found only in the gram-negative. These are trilaminar channels that are held through the outer membrane for passive transport. As we said, active transport happens within the internal membrane. The final thing to point out here is the presence of penicillin binding proteins. And these blue oblongs that I've shaded here, reaching through the cytoplasmic membrane, if you notice, they exist in both gram-positives and gram-negatives. And as the name implies, these are the molecules to which penicillin-style drugs attach. That's not actually the issue of how they function, except for the fact that penicillin binding proteins are actually enzymes that will create the cross-linkages within the peptidoglycan molecule. And so if I inactivate those enzymes by having them bound to one of these drugs, then the penicillin is made without, the peptidoglycan is made without those cross-linkages, and as a result, that individual organism would become susceptible to the ravages of osmotic pressure. So the way that the penicillin-style drugs work is by inactivating these cytoplasmic membrane enzymes that function in the cell wall synthesis. Okay? Other than that, realize when we talk about the function of these layers, much of this we've already discussed, that the capsule can be also called a slime layer or glycocalyx. Virtually all of these are made of polysaccharide, the one exception being Bacillus anthracis, which is a polypeptide capsule. And all of them are immunogenic to at least some degree, that antibodies can be made against them. The distinctions there would be Neisseria meningitidis, which makes a sialic acid capsule in the type B serotype, and Strep pyogenes, which makes a hyaluronic acid capsule. Now, I think you can imagine why it is true that neither of those molecules would be immunogenic. And of course, it's because they are a component of the extracellular matrix. Therefore, if you made an immune response against them, you would actually be becoming autoimmune. The outer membrane exists only in the gram-negative, and remember, it is the location of endotoxin. As we said before, the toxic component is lipid A, and this is also the region where I find outer membrane proteins, which can function in adherence, and porins, which function in passive transport. The cell wall, we already spoke about the difference between the intensity and cross-linkage, very thick in a gram-positive, thinner in a gram-negative, but made of the same molecule. This is the layer of the bacterial cell that gives it its shape and its protection from osmotic pressure. It's also the region that gives it its gram stain result, and probably, if you simply counted up the number of antibiotics that we have, it is the region that we target with the greatest number of antibiotics. We'll talk about those in a moment. The periplasmic space, remember, exists only in the gram-negative. It functions to regulate osmotic pressure, and things will diffuse in and out of the cell through there. And then the cytoplasmic membrane is the site of anything which requires membrane support biochemically, so oxidative phosphorylation and DNA replication, all of that, but also is the site where I find these cell wall synthesizing enzymes, carboxypeptidases and transpeptidases, which create the cross-linkages in the cell wall. Now, beyond that, realize that bacteria replicate by binary fission, which is an asexual process, And when I drop bacteria into a culture, I can see 4 phases of growth. Remember, this has no analogy to the eukaryotic cell cycle. It's simply if I drop bacteria in at time 0 and leave that culture until time immemorial, this is what the cells would basically do. So notice initially during the lag phase, there is no associated multiplication of the cells because of the fact that they are turning on the enzymes that they need in order to utilize the medium that they find themselves in. After the lag phase, the culture enters a logarithmic growth phase, which is the period where I have the organisms dividing 2 by 2 by 2 by 2 by 2 by 2 by 2, as long as they can, as long as there are sufficient nutrients in the culture, and as long as there's nothing toxic building up. So remember that during this period of time, this is when I could measure the generation time in the culture, the generation time being the length of time it takes for one bacterium to divide into 2. Next, when something becomes limiting, either I run out of nutrients or I have too many toxic byproducts being made, I'll enter the plateau phase on the growth curve, which basically indicates that the number of cells that are dividing is roughly equivalent to the number that are dying. I have not necessarily changed the rate at which one divides into 2. I simply have as many of the creatures dying as are dividing, so the graphic of the count of the cells hits a flat line on the top. And eventually, as the nutrients now are disappearing faster and faster, toxic products building up more and more, I reach a period of time when the number dying are greater than the number who are dividing. And so if I follow that to its normal completion, at the end I would have no one alive at the end in that culture. Okay? Now, some bacteria, there are 2 genera in fact, who will utilize the production of spores to protect themselves when something is unpleasant in their environment. And they are Bacillus and Clostridium. I don't think we need to get too obsessive compulsive about what it means to make a spore, but I do want you to remember that bacterial spores do not serve any reproductive purpose at all. So if a bacillus or a clostridium find themselves in an unfavorable environment, too hot, too acid, too alkaline, too dry, they will form a very rigid, impermeable cell coat of keratin and thicker than normal peptidoglycan, and they will create some enzymes that will allow them to protect themselves in that particular bad environment. They do not, when the environment improves, come out in multiples of their former self, but simply are of the same number. One vegetative cell actively metabolizing becomes a spore, and when things get better, the spore stops being a spore and goes back to being actively metabolic as a vegetative cell. So there are a couple of enzymes here that I think you should probably have name recognition for. And the reason is that the USMLE is very gifted at testing you on synonyms for things that you're not anticipating. They do this, in my belief, to keep you from simply having a depth of understanding that involves only one buzzword for something, because they expect you to truly understand what that word means. So if you see the words calcium dipicolinate or dipicolinic acid synthetase, realize that these are enzymes totally unique to bacterial spores. This is the only place you will find them. So they could technically use the mention of those 2 enzymes to highlight the fact that they are saying that Bacillus or Clostridium are present in that location. Now, as we talk about the spores of fungi later on, you'll find out that they are both protective from the environment and also reproductive. So the dissemination, the protection, and the multiplication of spore forms in the fungi is a very different biology. Now, as I told you before, the USMLE has phased out questions on laboratory techniques. But remember, some of the special nutritional requirements that bacteria or other creatures have can be mentioned as clues in a case history to give you an idea that they're thinking about one particular pathogen over another. So realize mycoplasma requires purines, pyrimidines, and cholesterol. If you recall, mycoplasma is the one bacterium that does not have a cell wall, and instead it has sterols in its membrane, which you have to provide for it in its diet. The four sisters Ella, Francisella, Brucella, Legionella, and Pasteurella, these are the four that require cysteine in their diet. So the memory tool here, the four sisters Ella worship in the Sistine Chapel. Now you need to be careful when you use that memory tool that you don't accidentally put Bordetella in the same bunch. And maybe the way to do that is to think of the four sisters Ella worshiping in the Sistine Chapel, but not Bordetella, because she is bored as Hella, and therefore she has fallen asleep somewhere else in the convent and is not where she's supposed to be. Hemophilus, if you notice, the name sort of tells you what you need to know about this one. Hemo, blood. Philus is from the Greek root to love. So this is a blood-loving organism. And what it loves in blood is factors X and V, protoporphyrin and NAD. And so I have to grow Hemophilus on a culture of lysed red blood cells, which we refer to as chocolate agar. Chocolate agar is not chocolate, contrary to what you might be thinking if you're having a snack attack right at the moment. Chocolate agar is just called that because of its sort of light brown color, but it's actually lysed red blood cells. Oxygen utilization can come up in questions. Realize most bacteria that harm or live with us are those that are aerobic, because we are aerobic creatures. And so because of the efficiency of the process, they will use oxygen as their terminal electron acceptor for as long as it's available, and then they will ferment when it's no longer available. So we refer to those guys as facultatively anaerobic. They'll use the oxygen as long as they can, and then they'll switch over to fermentation. Now, in order to capture oxygen from the environment, most of my facultative anaerobes will have superoxide dismutase, and my aerobes as well. This is the way it's captured from the environment. And the equation that results is that in the presence of that enzyme, I can combine oxygen and hydrogen and end up producing hydrogen peroxide. Now, most of the aerobes will take the additional step of using catalase, which is another enzyme, to change their H2O2 back into water and singlet oxygen, because of the fact that H2O2 is an oxygen radical, basically, and can be harmful to live in. So if I'm aerobic and I'm creating H2O2, it's going to be beneficial for my protection to also convert it back into water and singlet oxygen if I can. So now, looking at the groups of organisms that I think you should know, ranging from the ones who are obligately aerobic to the ones who are obligately anaerobic and everything in between, realize the aerobes require oxygen for their terminal electron acceptor. This is another way of saying that they're incapable of fermentation. They have superoxide dismutase, and most of them also create catalase. So the memory tool here, my nasal passages can breathe, okay? Of my obligate anaerobes who are killed by oxygen, there's no reason for them to have superoxide dismutase because they are exceptionally fermenters. They do not respire aerobically at all. So these guys can't breathe air as the memory tool. And then there is a subcategory of these that we refer to as aerotolerant anaerobes who produce catalase in order to allow themselves to be able to live in mixed cultures where someone else is producing H2O2. Now, those unusual ones, of course, are going to have to be mentioned as requiring something different about the incubator we put them in. And in that same way, the microaerophiles here in the center are said to be microaerophiles because although they use oxygen as their terminal electron acceptor, they require less than the normal atmospheric pressure. And so that means that they have to be grown in incubators that pump CO2 into the chamber when the door is closed. So they'll have to mention special incubation in the case of Campylobacter and Helicobacter, because I can't just use any old microbiological incubator. The mechanism of action of the major antibacterials, well, this is sort of a painful process here because, as you see, we have been treating bacteria for many, many decades, and so we have developed many drugs that unfortunately you're going to have to understand at the level of pharmacology. But I have at least outlined them for you here. Those that inhibit cell wall synthesis would largely be my penicillins, my cephalosporins, vancomycin, etc. Those that inhibit folate synthesis, my sulfonamides and trimethoprim. Those that attack nucleic acid synthesis may do it at the DNA level, the quinolones, ciprofloxacin, nalidixic acid, novobiosin, or at the RNA level, at the rifampins and streptoviricins and so forth. Those that target RNA elongation, actinomycin, and quite a large bunch tackle the unusual size of the ribosomes. So those that act at the 50S ribosomal subunit, the macrolides, clindamycin, chloramphenicol, etc. Remember, the tRNA specific ones are mupirocin and puromycin, and the ones that act at the 30S ribosomal subunit are tetracyclines and aminoglycosides, primarily. The cell membrane is the target of polymyxins and daptomycin. So with apologies, there are lots of drugs to be known here. The major question on the Step 1 USMLE as pertains to pharmacology in the antibiotics is going to be the mechanism of action. So make certain that you're familiar what portion of the life cycle is going to be inhibited by a given drug. Now, a couple of things about laboratory technique in very broad strokes, because you're not training to be laboratory technologists. Remember that if I have an obligate intracellular organism, I'm going to have to provide the cells for it to grow in. So if they mention tissue or cell culture, they're telling you that the organism is an obligate intracellular. Those that are extracellular or can choose, we call those the facultatives. Realize I have two basic strategies for selecting media. I can either use selective media, which adds special nutrients to allow something to grow or inhibit others with antimicrobics, or I can use differential media in order to allow lots of things to grow, but make them differentiable. I can tell the difference between them on the basis of their color or shape or something else. So out of the media that I think you probably should know from the point of view of them being likely to be mentioned in a case history because they tell you something about the causal agent. Remember, out of the respiratory agents, Corynebacterium is grown on either Loeffler's egg yolk agar or tellurite, which is a differential agar allowing us to see the grayish-black colonies that would distinguish Corynebacterium diphtheriae. Mycobacterium Lowenstein-Jensen is a selective agar, but remember that I generally don't grow Mycobacterium anymore at the stage that I'm trying to make the diagnosis because it's a very slow-growing organism. And so I have supplanted growth on Lowenstein-Jensen as a diagnostic technique with things like detecting niacin production or using a fluorescent dye. Legionella is grown on charcoal yeast extract agar. That's a agar that contains cysteine and iron. And remember, Legionella is one of the sisters Ella. For my enteric bacteria, remember, they're pretty much going to be willing to grow anywhere. Living in the intestines is not really like being on the French Riviera. So these I grow on a variety of different things, but most of them are differential media that will allow me to differentiate the fermenters of lactose versus the non-fermenters. And the one exception to the gastrointestinal organisms and the fact that most of them will do just fine in an acid environment is Vibrio cholerae, which grows on the most alkaline medium we have in a laboratory, thiosulfate citrate bile salt sucrose. Probably don't need to know the name, but remember, it's extremely alkaline. And that's something that's worth remembering about Vibrio, because Vibrio really doesn't like acid. So it is easily killed in acid environments, which translates to the fact that it's going to take a very high infectious dose in order to infect a person with Vibrio, because most of the organisms do not make it alive through the gastric acidity, and therefore you're going to end up having to have lots of them ingested in order to have a few of them survive and cause disease. The genitourinary organisms, remember with Neisseria, I have to tell the difference between normal flora gram-negative diplococci and the pathogen. So Thayer-Martin is a selective medium that allows me to distinguish the difference between the pathogens and the normal flora. It has antimicrobics and antifungals added. But if I'm simply trying to grow Neisseria from a site that should be sterile, then it's perfectly happy to grow on chocolate agar. And so that's what I would use if I'm trying to culture something out of the CNS. There should be no normal flora there, so I do not need a selective medium. Now, there are two stains that you probably do need to know how to do in microbiology. One is the gram stain, and the other is the acid-fast stain. For the gram stain, which of course is the foundational stain of microbiology, what you need to remember is all of the cocci that we have are going to be gram-positive except for Neisseria and Moraxella and Veillonella. Bacillus and Clostridium are both gram-positive. And remember that the test depends on the thickness of the cell wall. So anything that doesn't have a rigid, thick cell wall is not going to be gram-positive. And human tissues don't have a cell wall, so they would be the color of the gram-negative on the slide if I use a special stain that's modified for use on human tissues. So the way I perform this test is by starting out with crystal violet, which is a very intense purple stain. It's a very tiny molecule, and what it does when added is simply make everything purple. It's taken up by all of the organisms in the area, and so everything at this step would become bright purple. My next step is my critical one, because Graham's iodine is a complexing agent, which is going to bind the very tiny crystal violet molecule to larger molecules inside the cell. So when I then follow that step with a wash of acetone or alcohol, realize that the molecules of purple stain have now become bound to larger things inside the cell, so that when I try to wash them out, it will only wash out of the cells that don't have a thick cell wall. So the color will wash out of the gram-negative organisms, but be retained by the gram-positives. My final step is a counterstain, safranin, which is pink, and when I add that, the pink dye will become visible in the cells that were stain-free at the previous step, the ones who had the thin cell wall, and so at the end, I will have the gram-negatives being pink and the gram-positives being purple. Safranin goes into the gram-positives, it's just that it's difficult to see the difference between a little additional pink when you're looking at something that is already intensely purple. The second stain that we think you should know is the acid-fast stain, which may show up in two different names. Ziehl-Neelsen is one, Kinnuin is the other. And remember that we use the acid-fast stain for cells that have a very waxy cell coat. Mycolic acids are very long-chain fatty acids. And so the surface of these organisms is very similar to candle wax. So I have to either heat the organisms up to get the color in initially, or shock it with a change of pH. And that's the difference between the two types of stain. They're both acid-fast stains, but they use a different technique to get the initial dye in. So of course, this is the typical stain we use for Mycobacterium. Nocardia is said to be partially acid-fast because of the fact that it will stain irregularly after this test is performed. And again, human cells and tissues don't have a waxy coat. Therefore, they would be the color of the non-acid-fast cells in the culture. So my first step is to apply a very bright red stain, carbolfuchsin, either with heat or pH change, and that forces that pink color or bright red color through the waxy coat of the organism. All of the remaining steps are now going to be performed at room temperature and normal pH. So when I wash with acid alcohol, my waxy coat has reformed around the organisms who had it, and the dye will now be retained and impossible to get out. The wash will come out of the cells that don't have a waxy coat. So notice I will end up with my non-acid-fast organisms being colorless at this step, my acid-fast organisms still being bright red. So when I add a counterstain, methylene blue, I then would have that color taken up by my non-acid-fast cells, which will become blue. My acid-fast cells simply remain red. Now, notice that we don't go positive and negative here the way we talked about with the gram stain. And sometimes this is a little confusing to people because the term acid-fast is really used in the British use of the word fast. If you think of words in British English, like steadfast and hold fast. Those are terms that indicate that something is being held onto tightly. So in this same sense, my acid-fast cells are holding on tight to the primary stain. My non-acid-fast are letting go at one step, okay? So it's not that this is a rapid stain in the American usage of the word. When we talk about something being fast or slow, it means that it's something you can do rapidly. But that's not the sense of the word here. We're talking about holding on tightly. So that, ladies and gentlemen, brings you to the first day of the rest of your life. And realize that this is a very large, dense chapter with tremendous numbers of organisms. So this is a place that you could stop and take a break if you would like to for a couple of minutes, but we will resume when you come back and talk about all of the different groups of organisms that we will be dealing with in this chapter as an overview. So, as we compare this group of microbes, realize that the division of gram-positive and gram-negative that we spoke about before our little break is terribly important for dividing these organisms from one another. And so, as you'll see, when we talk about the organisms, I have organized this chapter in such a way that the most heavily tested organisms will be at the front of the chapter, and the ones that are likely to only generate a random question here and there will be held for the last. And this is because of, in many years of teaching this, I realize that you may all be in a coma by the time that I'm finished with all of these bacteria. So we want to make sure we get through the ones that are very heavily tested before you lapse into your comatose state. So we will start with the gram-positives, and by all means, the gram-positive cocci are hugely important. Staph and strep, notice the asterisks that I've put here, indicate that they are very heavily tested and will get multiple questions. The gram-positive bacilli are not as heavily tested, but certainly you will see questions on Clostridium and Corynebacterium and Mycobacterium. And as I speak briefly about Mycobacterium, notice that I've also got it listed over here in the organisms that don't stain with the gram stain. And so let me explain that designation to you here. In the organisms who don't stain with the gram stain, we've got some that are intracellular, like chlamydia and rickettsia, and then we've got some that don't stain well for other reasons. Mycoplasma, because it doesn't have a cell wall. Mycobacterium, because, as you know, it's very waxy. But they still have an underlying anatomy that makes them either more closely allied to a gram-positive or to a gram-negative. And if you remember, the key thing about that distinction is that my gram-negatives have endotoxin because of the fact that they have an outer membrane. So realize that what I'm saying when I say that something has a gram-negative anatomy, even if it doesn't stain well, I'm reminding you that when you go into the drug treatment phase dealing with one of those microbes, you have to consider that the drugs will kill the organism and release the lipopolysaccharide, and so you can have the signs and symptoms of endotoxin shock. Mycobacterium and Mycoplasma do not have an outer membrane. Therefore, they are much more closely allied anatomically to a gram-positive. And the reason why I will handle Mycobacterium over here along with the gram-positives is because of the fact that it's an important organism. And again, I want you to hear about it before you lapse into your coma at the end of the chapter. Now, my gram negatives, I have a small bunch of gram-negative cocci, and of these, I would say Neisseria is the only one that will receive more than one exam question. The remainder of the gram-negatives are all bacilli, also known as rods, and so we'll deal with the family Enterobacteriaceae, and the others will get relatively minor questioning, with the possible exception of Haemophilus, which normally generates a couple of questions at least. But by all means, the most important of these will be at the beginning of the chapter, and so those are the ones that you should concentrate your time on. As we look at the gram-positive cocci, remember that the first thing that you want to be aware of as you consider these guys is that the laboratory results will come back specifying whether the creature is catalase positive or negative. Okay? The catalase test is done by taking colonies and simply flooding them with hydrogen peroxide. If the organism is making catalase, then you will bubble up water and singlet oxygen. And so the gas, of course, is the oxygen that you're seeing. If it's a positive result, then you know that you have the genus Staphylococcus. If you get a negative result, then it is the genus Streptococcus. We're going to start with Staphylococcus, of course, who has the name designating what it looks like. Staphylo is from the Greek and means clusters of grapes. And coccus, of course, means a spherical, circular sort of creature. So after I establish that I have a catalase positive organism, my next step is to look at the results of the coagulase test. And coagulase is an enzyme that converts fibrinogen to the fibrin clot. So if I get clot formation, then I say it is coagulase positive. If not, then it's coagulase negative. Notice I can stop at the point that I find coagulase positive because the only organism who is coagulase positive and catalase positive is Staphylococcus aureus. And in fact, in all of the pages of this chapter, there will only be one other organism that we will talk about that is coagulase positive, and that is a gram-negative rod, Yersinia. Okay? So there truly are only 2 coagulase positive bacteria that you need to know, and that makes that particular enzyme system quite an easy one. Now, remember other things about Staphylococcus aureus. The species name, aureus, refers to the fact that it makes golden colonies on blood agar. It's beta hemolytic, meaning it breaks down hemoglobin to its colorless byproducts, and it ferments mannitol on mannitol salt agar. Now, I always stress to students that microbiology can come to look like simply a mountain of trivia to memorize, but I would argue that not all facts are created equal. And so I always encourage students to remember that Staphylococcus aureus is what we call a halophilic organism. In other words, it loves halides or salt, okay? And that's going to factor into a lot of different diagnostic clues that you can look for if they're trying to get you to make a diagnosis of Staph aureus. We'll come back to that in a moment. Now, if my result was that I had a coagulase negative organism, coagulase negative Staphylococci is the abbreviation that you will see, my next step is to try to drop a disc that has novobiosin antibiotic in it on the surface of the agar petri dish. If the organism is willing to grow right up against that novobiosyn disc, it is resistant, and I know that it is Staph saprophyticus. This is the cause of what we call honeymoon cystitis, or a urinary tract infection in young, newly sexually active women. Okay, I do want to emphasize to you, however, that until you have proven to you that what has been cultured out of the urine is a gram-positive coccus that is novobiosyn resistant, you should not make the diagnosis of Staph saprophyticus in any case of UTI. You should remember that UTI is always E. coli until proven otherwise. So they would have to give you the culture findings in order for you to make that diagnosis. And be careful, because often, again, students get these buzzwords in their mind and they don't think about the fact that the number one cause of UTI overall is E. coli. Now, if my result with novobiosyn is that the organism is not willing to grow anywhere near it, then I've got Staph epidermidis. And this is the most common cause of infections of catheters and prosthetic devices. The reason being that we always coat these materials with Teflon if we're planning on leaving them in the body over a time. And Teflon is still the most slippery thing that has ever been created in a laboratory, many decades after it was first created. So this is because of the fact that the organism is capable of making a biofilm, which allows it to adhere to that otherwise very slippery substance. Now, Staph aureus, very, very important organism. As I said, notice all of the things about it being halophilic that are useful to you. It's going to be normal flora in my nose and on my skin, both of which are relatively salty locations. It's transmitted by sneezing from its site of normal flora. It can contaminate surgical wounds, and it also can be transmitted by contaminated food. And you'll notice as we go further that the thing that these foods have in common is that they are salty foods in which the organism is very happy to grow. Any problem that is going to cause an issue with my normal barrier systems, like breaks in the skin or foreign bodies or IV drug use, realize are going to allow from the introduction of the normal flora into the body. And if you think about it, IV drug abusers tend to have more poor personal hygiene than other persons would. And so they would be anticipated to have a higher salt concentration on their skin, which can mean that I actually have more Staph aureus there than other normal flora organisms. Anything that causes me to have difficulty dealing with extracellular organisms by my innate immune response, if I've got problems with my neutrophil number or their activity, if I have chronic granulomatous disease, remember this genus is catalase positive. So my CGD patients would be at risk because of the fact that with a catalase positive organism, both of my oxygen-dependent killing mechanisms intracellularly are impaired. Cystic fibrosis patients, again, notice my chloride imbalances in this case. On the skin tends to have these organisms grow more happily on those patients. When we think about the different scenarios that can be made into case histories with Staph aureus, you'll see that it's really a huge list. Staphylococcal food poisoning is special because it causes onset of vomiting and diarrhea within 3 to 6 hours of a meal. There's only one other thing that will cause this rapid an onset after a meal, and that, of course, is going to be Bacillus cereus. And I can distinguish between them because of the fact that this is going to be associated with salty foods that are typically taken to a picnic. So any mention of someone attending a picnic, the idea is that the toxins are preformed in the food after the food is prepared, and then during the transport from the refrigerator to the location of the picnic, the toxin will be made. So very, very common. Realize they like to ask about those therapies that do not involve drugs. So it's only supportive care in this case because of the fact it's not actually an infection with the organism. It's simply a toxicosis. You have ingested the preformed toxin, thus the very rapid onset, and thus no antibiotics recommended. Okay? Please make certain that you notice as you go through these notes, this has become an increasingly common question. And it's become an increasingly common question, in my view, because of the fact that they recognize that drug resistance is getting to be such a problem. But asking you what sorts of conditions should not be treated with antibiotics is the question. So make certain you know in those scenarios where we don't use antibiotics, we simply use supportive care. All right. Now, next, if we think about staphylococcal endocarditis, my patient would have a very acute onset, a very abrupt and dangerous clinical course. And so realize I did not put into this the mention of splinter hemorrhages, which everyone associates with bacterial endocarditis. But the reason why I did not mention that is because of the fact that most patients with staphylococcal endocarditis will be dead before they have splinter hemorrhages. So in my view, if they were to give me a scenario with someone who had splinter hemorrhages, I would be saying to myself, that is probably not Staph aureus because it's not an acute onset. So remember, generally when we talk about bacterial endocarditis, we differentiate the acute and the subacute. And Staph aureus is acute. All of the rest of them are subacute. So they will be spoken about differently. All right, treatment. Depending on what I get from the cultures, I will start with the heavy arsenal drugs. And remember, I've got quite a bit of drug resistance in Staph aureus. So I will usually start empirically treating against MSSA, but be prepared very quickly to assume that it's going to be methicillin resistant or even vancomycin resistant. If I have cough and fever, then realize Staph aureus is a relatively common cause of typical pneumonia, and you should associate typical pneumonia with, again, acute onset, high fever, productive cough, lobar consolidation. So typical pneumonia, if you're thinking immunologically, is the clue that this is something that is bacterial in origin. My typical pneumonias are my bacteria. My atypical pneumonias are my viruses and atypical bacteria, okay? But notice that this one is most likely going to be after influenza. It may be associated with ventilator use. And when we're looking at the typical pneumonias, in order to tell them apart, we know by definition that they're all going to be bacterial because all of those symptoms and signs reflect the infiltration of neutrophils and the causes of neutrophils exploding and turning loose interleukin-1 and fever and so forth. But remember, within the typical pneumonias, I look at the appearance of the sputum in order to tell them apart. And sometimes this is described as salmon colored. It's that basically pale pink in color. So there's some blood, but not a huge amount. When I speak about osteomyelitis associated with Staph aureus, remember this is the number one cause, unless they mention to you a patient with sickle cell anemia. Okay, in that case, they're after salmonella, you probably remember. So think of the three S's going together. But otherwise, all cases of osteomyelitis, you start with Staph aureus and you rule out others as they tell you more about the patient. Now, how does the organism get into the bone? Well, there has to be some sort of traumatic injury. And so the introduction from the normal flora location into through the skin and into the blood is mentioned. Notice in each of these cases, I've got the same list of virulence factors which are important. Coagulase inhibiting phagocytosis, the alpha toxin of the organism causing cellular lysis. And so indeed, that's what I'm seeing on these lesions when I image the osteomyelitis diagnostically. When I speak of skin or subcutaneous infections, this can be a mastitis in newly nursing mothers. It can be a condition where I have diffuse epidermal peeling in the case of exfoliatins being produced by the organism. Those are proteases which cleave cadherin desmoglein 1, and so those are the cause of the bullous vesicles that I see in staphylococcal impetigo. Okay, impetigo can be one of two things. It can be staph or strep. Okay, usually with staphylococcus, it's a slightly older age group of child. And remember, the production of those vesicles tells you that the exfoliatins are the cause of the problem. When I think of streptococcal impetigo, as you'll see shortly, that's typically a weeping, oozing condition that is sometimes described as looking honey-crusted. Okay? Now, in the case of post-surgical skin infections, I can get the toxin-producing strains, which remember act as superantigens. If I get them introduced into the blood, then I've got big problems. Because remember, when I have a superantigen, what's going to happen is I'm going to turn on that massive cytokine storm. And as a result, these are very, very dangerous conditions. And again, I have enough drug resistance that I probably am going to have to start empirically and then move upwards as I go. One of the other times that I see toxic shock syndrome toxin being produced is in cases where I've got surgical packing. They no longer as often mention extended use tampons, although that was the fad for a while. They now regard that as a buzzword, and so they've moved into post-surgical TSST, skin infections extending into deeper tissues. And it always starts with a scarlatiniform rash that desquamates because of the exfoliatins. And remember, it's going to involve the palms and soles. It's relatively uncommon for rashes to involve the palms and soles, so make a note of that when you see it. Staph aureus is our first one that will do that. Of the rest of them, there really aren't very many. The next one we'll come to in order will be treponema. The agent of syphilis involves the palms and soles. And then we'll get to Rocky Mountain spotted fever, which also involves the palms and soles. And then within the viruses, we'll have Coxiella, Coxsackie. So really a total of 4 agents that cause a rash involving the palms and soles. So that's a pretty good unusual clue. That brings us to the coagulase negative staphylococci. And remember, these guys are divided from one another by either being sensitive or resistant to novobiosin. It's not going to be an intense question on these, but remember, my ones who are sensitive are my major cause of infections of catheters and prosthetic devices, and may also cause a subacute endocarditis in IV drug users. Subacute endocarditis would have a slower onset. The patient would notice fatigue and anorexia and low-grade fever. And in this case, a murmur and splinter hemorrhages would be seen, okay? But it's going to be one that we see in IV drug abusers if they are a subacute case of endocarditis. In the case of saprophyticus, it is an agent of UTI in young women, but remember, they'll have to give you the culture characteristics before you would rule out the possibility that would be E. coli, because E. coli always wins. Now, that brings us to the genus Streptococcus, which is a massive bunch of creatures. And it's gotten to be such a mess at the current time that I really struggled with what to put in the notes on the topic of this group of agents. What I have done is given to you what is the current designation of the taxonomy, but keep in mind that the more that they're doing MALDI-TOF, which stands for matrix-assisted laser desorption, ionization, time-of-flight mass spectrophotometry, they're analyzing these organisms and re-taxonomizing them into different families. So these are the gram-positives, catalase negatives, cocci in pairs and chains. They're first defined by their pattern of hemolysis. Do they make biliverdin? Do they make a colorless product? Do they not degrade blood at all? And then after that, they are put into what we refer to as their Landsfield group, based on the Nobel Prize work that Rebecca Landsfield did to divide these into different groups. And what she did was analyze them on the basis of their cell wall carbohydrates. So, looking first at the pattern of hemolysis, those who are beta hemolytic are the ones who will break down hemoglobin to a colorless product. And if you remember the hemoglobin degradation pathway, the bilinogens are the colorless products of hemoglobin degradation. My alpha hemolytic creatures break down hemoglobin to the green product, which you'll remember is biliverdin, and my gamma hemolytic organisms do not hemolyze at all, so the agar would remain red. So they'll have to tell you that particular issue, and then I go down into subcategories of characteristics. In my beta hemolytic organisms, I then will add a basotracin disc to the top of the agar. If the organism is not willing to grow anywhere near it, then I say it is the group A Streptococcus, Strep pyogenes. If it's happy to grow up against the basotracin disc, then it is Strep galactiae, also known as group B strep. And my further test to distinguish that one is a positive CAMP test. Now, a CAMP test is not a test for cyclic AMP. It's a test for an additional incomplete hemolytic agent. And I'll talk about that a little bit more in a moment. But notice the major way to distinguish between group A and group B is the sensitivity to basotracin. For my alpha hemolytic organisms, they will make a green coloration to the agar. I'm then going to ask if they are sensitive to opticon, and lysed in bile. So the one who is sensitive and soluble, respectively, to opticon and bile is strep pneumo. And notice that we say that these guys are not groupable because they don't have that C carbohydrate in the cell wall. Therefore, Rebecca Lansfield could not put them in a group. Those that are insensitive and insoluble to opticon and bile, respectively, are the viridans group streptococci, which are the normal flora of the mouth. Okay, so think about opticon and bile separating my organisms into the ones who are sensitive and like to live in the lung versus those who are pretty tough and are willing to live in the mouth in the presence of a fair number of early digestive enzymes. My final category, the gamma hemolytic ones, these are the ones where there has been most taxonomic change, and it really is still being reorganized as we speak. But the best test for these guys is that they will make black colored pigments on bile esculin agar. They're distinguished from one another on whether or not they tolerate high levels of salt. Okay, salt intolerant would be Galolyticus, which used to be Bovis, and tolerant of high salt is Enterococcus, which is not even in this particular genus anymore. It's an unrelated genus, but I left it here because we're still using these same techniques to distinguish between them in the laboratory. Okay, now, if you're thinking that this looks like a hopeless level of memorization at this point, as we are only on the 16th page of this chapter, realize there's an easy trick to remembering these, and that is that the name of the group is always one alphabetical letter from the test which is used to distinguish them. So for group A, I have basotracin sensitivity. For group B, I have the CAMP test. For group D, I have growth on esculin agar. So A, B, B, C, D, E so far. And then with the pneumococcus, with strep pneumoniae, I can't use a group letter because they don't have that C carbohydrate. They're not groupable. So for the pneumococcus, I take the P as the slang first letter and remind myself that I test for it because of its opticon sensitivity. So that takes that whole algorithm, which otherwise can look sort of mind-numbing, and simplifies it down to, can you remember the order of your alphabet after you've been staring at a computer screen for 8 or so hours a day? And I can't guarantee even that, but you have to admit the alphabet makes it slightly easier. So, starting with strep pyogenes. Clearly a very important agent, also known as group A strep. Know the synonyms. These are used totally, absolutely interchangeably. Now, these infections are most common in children. We tend to see the acute infections still in the United States, but the post-streptococcal sequelae we do not see nearly as much as they would be seen abroad. Transmission from throat and skin via respiratory droplets or contact. If we think about what the patients can look like, an acutely sore throat and fever, this is strep throat, streptococcal pharyngitis. So realize because it's an extracellular, I'm going to see abscesses on the tonsillar pillars, I'm going to have local lymphadenopathy, and I'm going to perform a rapid strep test, which is only good to a point. It will miss about 1/4 of the infections that are actually truly there. And so what I have to do is culture anything that got me a negative result. I have to culture it on blood agar, with a basotracin disc. Now, I did not mention the PYR test as we went through the algorithm a moment ago, because I didn't want to overwhelm your brain to the point of death on the first page of the streptococci. But the PYR test is a test for an enzyme. And the problem with this test, well, I guess I should start with the good things about the test, is that it's a very rapid test for an enzyme. The problem being that that enzyme is possessed both by group A and by some of the group D. So it's not an absolute distinction between the streptococci, but at least I know that if they tell me PYR positive, it has to be either group A or group D, okay? Now, how is it causing disease? Well, it adheres with pili and a fibronectin-binding protein, teichoic acids, all of those things cause adherence. It has a non-immunogenic capsule, and it impedes phagocytosis. And then it has a surface protein known as the M protein that is used for serotyping within the species. Remember that the M protein prevents opsonization using complement component 3B. Now, scarlet fever we do not see in the United States anymore because we tend to treat quite aggressively with penicillin or amoxicillin when we see a strep throat. But scarlet fever can follow on the initial sore throat and then develop the rash that begins around the mouth and tends to coarsen the appearance of the skin to be like sandpaper. The tongue will become first covered with a fibrinous exudate, and then as that peels, I will see those very prominent bright red papillae. Okay, so they're going to have to describe that as being in a child from outside of the United States, because we simply do not see scarlet fever anymore in the United States. It is the exotoxins that are erythrogenic. These cause the fever and rash. And remember, they act as superantigens. And then, of course, the enzymes that tend to degrade the extracellular matrix and cause the hemolysis that we see on the blood agar. The skin infection of the organisms here, remember our second cause of impetigo, but in this case it's going to be a weeping, oozing condition where the fibrinous exudate is sort of crusted on the surface of the skin. It tends to be a younger child than staphylococcal impetigo, but there is enough overlap that can't be your only criterion. We treat with mupirocin or retipolamine. The subcutaneous spread, remember that this is one of a category of organisms that we can refer to as being a flesh-eating organism because of all of these enzymes that it uses to degrade the extracellular matrix. So typically, in addition to drugs, we have to do debridement, which often means very aggressive amputation, basically, or at least very profound cleaning around the initial area. We talked about the non-suppurative sequelae of Streptococcus as we went through the immunology chapter on hypersensitivities. Remember that when I have streptococcal rheumatic fever, my problem is going to occur about 3 to 4 weeks after the pharyngitis. Again, an immigrant child. I'm going to measure the antistreptolysin O titer, and anything over 200 is considered diagnostic. The M types tend to be the lower number serotypes of the M protein. And of course, it's a type 2 hypersensitivity, as we talked about before. Post-streptococcal glomerulonephritis is going to be about 10 days and can follow either the pharyngitis or the impetigo caused by group A strep. It's a type 3 hypersensitivity. Okay. The mention of using penicillin in each of these cases is sort of questionable. I guess it can be argued that one needs to make certain that there aren't any more organisms still in the body, so it's more or less of a protective regimen. But remember, these are post-streptococcal sequelae, so these are after the acute infection, and the only rationale for using antibiotics in these would be to make absolutely certain that there aren't any persistent antigen exposures that would be causing these hypersensitivities to persist. Streptococcus agalactiae is going to be a simple one for you, a much more minor one. Remember, this is found in the vaginal fluids of 15 to 20% of women normally, and so it can be transferred to a neonate during passage through the birth canal. The child then inhales it, it moves into the blood, and then it survives neutrophil phagocytosis to be able to cross the blood-brain barrier. So this is the #1 cause of neonatal meningitis and septicemia in the United States. And while we're on the topic, let's go #1, GBS, #2, E. coli, and #3, listeria. So notice as we go through these notes, when we talk about meningitis, one of the key criteria that you will use to distinguish which is the most likely causal agent is the age of the patient. And neonatal is the first month after birth. So within that first month, GBS and E. coli would tend to onset somewhat more rapidly than listeria. Listeria is going to be second week and beyond, as you'll see as we move into the gram-positive rods. Okay, it is encapsulated. That's actually a strategy that is necessary for virtually all of the agents of meningitis. They have to have a way to survive neutrophil killing in the blood. It has a beta hemolysin and an additional partial hemolysin, and I detect that by growing it alongside of Staph aureus. Treatment, ampicillin with an aminoglycoside, and if I know that a woman is a carrier, then it's easier to protect against this by giving her ampicillin or penicillin during delivery. Strep pneumo, this one, normal in the upper respiratory tract, causes problems when it gets down below. And as we mentioned as we were going through the microbial genetics, remember this one has 93 different serotypes of capsule. And those organisms in my upper respiratory tract are natural transformers. So they are constantly sharing capsular antigens and causing the problem of antigenic variation, basically. This is the #1 cause of typical pneumonia, #1 cause of adult meningitis, #1 cause of otitis media and sinusitis, so a very important agent. When we think about the typical pneumonia, rusty sputum, that should imply to you that the blood is being produced relatively deep in the lung and is being oxidized as one coughs it up. The more red blood is that you're coughing out, the more high it's being produced in the respiratory tree. If it's brown by the time it gets to be coughed out, it implies that it has lots of time to oxidize. So this is a problem in the alveoli that we're seeing where the blood is being generated. Of course, typical pneumonia, lobar, high fever, acute onset, and then if you're lucky, you may find encapsulated diplococci in the sputum. That is not a terribly sensitive test, but remember, this would be the number one cause, which is your default position, regardless. Any sort of damage to the mucociliary escalator previously is going to make you be at risk for this. So antecedent influenza, COPD, congestive heart failure, alcoholism, all of those things impede natural cleansing mechanisms out of the lung, either from the respiratory or from the circulatory side. It is an IgA protease producer, so it destroys the local immunity. It uses teichoic acids for attachment, and it has an anatomical toxin named pneumolysin O that damages the respiratory epithelium, shuts down the respiratory burst, and inhibits complement fixation. So it's a serious pathogen. We treat with macrolides. When we're talking about the organism causing meningitis, remember this would be the most common cause in any adult, unless they're talking about adolescents in crowded living environments, in which case you'd probably be thinking Neisseria. And unless you're talking about an immunocompromised patient, in which case some other things would get onto the list. But number one cause of otitis media, of meningitis, and of typical pneumonia. Now, with meningitis, of course, we're going to do a CSF tap, and you're going to find elevated neutrophils because it's an extracellular bacterium, depressed glucose levels, and increased protein. Okay? The Quellung test or latex particle agglutination are tests to look at the capsular antigens. And the only problem with those tests is remember that there are Quellungs and LPA tests for virtually every agent of meningitis. And if that's true, it means that they have to give away which one they want you to diagnose. I can't just say Quellung was positive or LPA was positive. I have to say LPA for pneumococcus was positive, or LPA for Haemophilus was positive, or LPA for whatever. I have a different one for each of the agents that causes meningitis. Now, if I have a splenic patient, I'm going to have problems with encapsulated organisms in the blood. So that would be a predisposing condition. Otitis media, typically not cultured, simply an issue of identifying it as a extremely cranky child pulling on their ears. You can see, of course, the tympanic membrane that is swelling in red inside the ear, but typically we don't culture. We don't do any other diagnostic other than simply going directly to amoxicillin at the point that we've decided therapy is necessary. We talked about the vaccines previously. You should make sure you understand the strategies here. My conjugate vaccine is the one that is conjugated to a protein, namely the diphtheria toxoid. It protects against only 13 capsular types. The one that is the polysaccharide vaccine with no conjugation has 23 serotypes. So the current recommendation by the Centers for Disease Control is to start with the pediatric, and then in the case where we've got elderly patients, 65 and beyond, we would go for yearly boosters with the polysaccharide one, just so we get those additional serotypes covered. In children, we go through the entire course with the conjugated vaccine, because remember, children can only develop good immune responses to T-cell dependent antigens. The viridans group of streptococci, these are normal flora of the mouth. So if this were a dental exam, they would be asking you about plaque or dental caries. But remember, overall, this is the group that is the most common cause of causation of subacute bacterial endocarditis, especially if the patient has pre-existing valvular damage in their heart. So notice, as opposed to Staph aureus, which is my one acute endocarditis, this is going to be an indolent onset of fatigue and fever, malaise and weight loss, splinter hemorrhages, and Janeway lesions. Those are both caused by septic emboli. And then, of course, I've got immune complex deposition, which are going to be the painful lesions that we refer to as Osler nodes and Roth spots that you can see in the eye. Okay, so what happens here, if you think about it, we all have these organisms in our mouth. And so we have an immune response against these agents, so that if they escape into our blood from some sort of dental therapy, then what happens is that there are immediately immune complexes made, and those immune complexes would normally be cleared out in the spleen. But if something happens that diminishes that immunity briefly, then I can get this very transient bacteremia. And then what I see causing this group of signs and symptoms is really the damage to the endothelial cell that's causing the release of those classic mediators, interleukin 1 and 6, and interleukin 8 and tumor necrosis factor alpha. There is some disagreement about whether or not the biofilm is contributory. Most people are saying now that the most common cause, which is sanguinous, is actually directly causing the damage by producing hydrogen peroxide. And that's what causes the damage rather than the ability to make a biofilm. Certainly biofilm production is important in causing plaque and dental caries, but the H2O2 seems to be the major local cause of valvular damage. We always give antibiotics prophylactically prior to dental work, especially in people with pre-existing damage. But remember, as we age, we simply have sort of wear and tear damage. And so often it's not known what the underlying existing damage is at the point that the problem occurs. For our group D streptococci, which, as I said, have now been totally disrupted by MALDI-TOF, I'm still going to talk about Enterococcus here, even though it's an entirely different group. And remember, Strep galliticus used to be called Strep bovis. So normal flora of the colon and urogenital tract. So when they get into your bloodstream, you've actually given them to yourself. That's endogenous transmission. They are agents of subacute bacterial endocarditis. And the list of things that one can get from hospital-acquired infection, these are one of the top 3 sets of agents. So when we have an elderly male who has undergone some sort of prostate therapy or damage to the bowel, then the escape of these organisms into the blood causes subacute endocarditis. And this would have all of the classic signs and symptoms we talked about before. Remember the culture on bile esculin agar and the PYR test being positive, Enterococcus being haloduric, meaning it tolerates salt, Galliticus does not. Remember that most of these come from some sort of lesion in the bowel or urogenital. So if you don't know what the escape route has been, you better go back and try and figure it out by colonoscopy. They exist in persons with pre-existing valvular damage, but again, it may be nothing more than simply being elderly that is causing that problem. Now, remember that this group is particularly bad for drug resistance. Vancomycin-resistant Enterococcus began here and has now spread that multi-drug resistant plasmid to other organisms. So remember that we have to be extremely careful using vancomycin in this case, and usually it involves starting with a drug empirically and then going back and figuring out what our sensitivity really was when we get it cultured. In addition, we can certainly see cholecystitis and cholangitis with this group because of their relative tolerance to salt and bile. And we can also have urinary tract infections. Typically, those are associated with some sort of catheterization or medical instrumentation. Treated with ampicillin, but again, remember, all of these have a very high level of drug resistance. You start with one thing empirically, but almost always have to switch over into another one. So that's probably a good place for us to take another brief break. And when we come back, we will move into the gram-positive bacilli. But I would want you to remember that what you've done so far now with the gram-positive cocci are going to be a really important source of questions because of the number of different diseases that are caused by these very important organisms.